Surgeons should have a basic understanding of the capabilities of a non-invasive vascular ultrasound examination for arterial and venous diseases. Ultrasound of the vascular system is most commonly done to exclude aneurysmal disease, evaluate the patency, flow, detect intimal disease in the arterial system, and to exclude venous thrombosis. Ultrasound can aid indirect vascular testing such as determining ankle brachial indices. This module will focus on direct visualization of vessels with ultrasound. Direct imaging is often called duplex. It utilizes two modalities: imaging the vessel and using Doppler to determine the flow of that vessel. Examples of this technique include pre- and post-revascularization surgery to assess integrity and anastomosis of grafts. It's also useful in the detection of aneurysms or pseudoaneurysms, demonstrating the patency of AV fistula, and detecting arterial stenosis. Ultrasound provides a rapid method to detect the presence, size, and integrity of abdominal aortic aneurysms. A rapid ultrasound examination is an essential technique to exclude aneurysmal disease in an unstable patient with a suggestive history. Intraoperative ultrasound can help assess the integrity and arterial flow through a graft or arterial anastomosis. The technique provides a rapid structural assessment of the geometry of the anastomosis and information about blood flow through the repair. Venous duplex is the most frequently ordered study to determine presence of deep or superficial venous thrombosis. Due to its high sensitivity in detecting the presence and location of thrombosis, ultrasound has essentially replaced invasive tests like venography. Veins in the leg can be imaged in the transverse or short axis. The veins are compressed with hand pressure from the probe over their entire length. Normal veins will compress completely. Veins occluded or partially occluded will not completely compress. Even very acute thrombosis that is not yet visible by ultrasound resists compression completely. Color flow and spectral Doppler detects the flow signal characteristics of the vein. Normal vein Doppler signals are patent, spontaneous, and change with respiration. They can be augmented with a squeeze of the leg from below. For example, a continuous signal indicates proximal occlusion. A lack of spontaneity of a signal can indicate obstruction in the vein. Two official accreditation bodies administer the Vascular Laboratory Accreditation. Intersocietal Commission for the Accreditation of Vascular Laboratories and the American College of Radiology each have specific rules and regulations guiding quality control, reporting, policy, and procedure. There is some variability between laboratory protocols for deep venous thrombosis. Some vascular laboratories do not scan the calf veins. These laboratories may still use venography to detect DVT in the calf. As ultrasound imaging has become more available and image quality and penetration has improved, DVT may be less prevalent in the future. Harmonic imaging is a newer technology that allows for the best of resolution and penetration. Harmonics sends the ultrasound through the body at one frequency and receives the reflection back at twice the sent frequency. Most vascular imaging applications of newer ultrasound systems allow for harmonic imaging. Three-dimensional vascular is not ready for prime time, but is an interesting development in vascular imaging. 3D vascular imaging requires the probe to be moved along the area of interest, and a 3D image is reconstructed from the slices. Contrast enhancement is a research technique that may be applicable for vascular ultrasound in the future. The contrast agent may be able to detect inflammation from increased flow within the vasovasorum. Endovascular leakage may also be identified with the aid of contrast-enhanced ultrasound. This duplex ultrasound examination of the right groin shows a 60-year-old male 5 days following a cardiac catheterization. He describes slowly increasing pain and swelling in the right groin. This is suggestive of a pseudoaneurysm. The ultrasound examination shows a pseudoaneurysm originating from the common femoral artery. The active flow-filled cavity measures about 1.5 by 2.5 centimeters. It displays a swirling color flow pattern. The neck between the cavity and the common femoral artery is about 4 millimeters in length. The flow pattern in the adjacent femoral artery is normal. There is no evidence of an arteriovenous fistula. The spectral waveform taken in the pseudoaneurysm neck shows the typical to and fro flow pattern. The presence of a relatively large symptomatic pseudoaneurysm with a discrete neck makes this lesion suitable for treatment by ultrasound-guided thrombin injection. Using ultrasound guidance, a 21-gauge echo tip needle is advanced into the active cavity. The tip of the needle is seen entering the cavity from the upper right of the B-mode image. Flow can be visualized around the needle on the color flow image. 0.5 cc of topical thrombin is injected. 30 seconds later, the cavity is thrombosed, and no flow is visualized. The needle is then withdrawn. Additional scanning documented persistent thrombosis of the pseudoaneurysm cavity and normal flow in the adjacent femoral artery and vein. The right ankle brachial index remained normal at 1.0. The vascular laboratory plays a key role in both the diagnosis and treatment of post-catheterization pseudoaneurysms. Pseudoaneurysms less than 1 centimeter in diameter can be difficult to inject, and they may thrombose spontaneously. Rapidly expanding pseudoaneurysms may require open surgical repair. This is also true for those with large arterial wall defects or no connecting neck. Using an etched needle during pseudoaneurysm injection helps to visualize it on the ultrasound image. Alternately, the barrel of a standard spinal needle can be scored with a scalpel blade. For the injection, a specific scan plane must be selected. It should show the pseudoaneurysm cavity and adjacent vessels in the same image. This allows entry of the needle as far away from the native vessels as possible. The needle is oriented in the plane of the image. Endo leaks are relatively common after endovascular aortic aneurysm repair, or EVAR. Regular follow-up imaging is required after these procedures. CT with contrast is generally regarded as the standard for post-EVAR imaging. However, the associated risks of iodinated contrast and radiation exposure make alternative imaging modalities desirable. Clinical experience indicates that duplex ultrasound can serve this purpose in selected patients. Included here is an example of duplex follow-up after EVAR. This patient underwent EVAR 6 months prior to this examination. This color flow ultrasound examination was performed in a patient who had an endovascular aortic aneurysm repair. The examination shows evidence of flow outside of the endograft, but within the excluded aneurysm sac. This appears to be a type 2 endo leak. Based on its location, this is most likely related to a patent inferior mesenteric artery. The flow in the area of the endo leak has a relatively high velocity of 135 centimeters per second. Vascular ultrasound consists of many techniques with clinical applicability for the practicing surgeon. It's essential to understand the capabilities and limitations of ultrasound in the evaluation of the vascular system. Increased knowledge of vascular ultrasound can be gained in a separate course on vascular ultrasound following this basic ultrasound course.